morning. Good morning, everybody. I will be speaking about evaluating a preschool child's eye and estimating her vision. The purpose is to get baseline information, identify children with eye problems and vision abnormalities, and also risk factors. So when do we check a preschool child? Formal testing should be done around 3 to 3.5 years of age or before school admission. Following this, if everything is all right, annual school camps are sufficient. Why is it a challenging task? Because of poor level of cooperation, poor attention span. It is time consuming. Both the patient and the doctor need a lot of patience. Endpoint of refraction is usually difficult to determine. Every time we check, there could be a variable response, and these charts are also helpful in special kids. So I've divided the examination into two parts. The first part is all about creating a rapport, creating a comfort zone. Because the child has a limited attention span, we do the most important test first. We have to be creative, flexible, get a detailed history from the parents. Any significant family history has to be documented, and during this time, we look for a compensatory head posture, if any. We do the Bruckner test first. We look for any leukocoria or deviated eye with a bright reflex. Binocularity is tested first. Simple test for stereopsis in preschool children could be 2-pencil test or Frisbee or Lang stereo test, which do not require the use of dissociative glasses. Older children can be more cooperative for demanding tests. So visual acuity tests are divided into 3 groups: detection, resolution, and recognition. Depending on the age of the child, we decide which test is to be used. Irrespective of the test that we use, the strategy is the same. We do binocular testing first to create a comfort zone and also look for any compensatory head posture. Then we test the better eye, and then we move on to the poorer side. So this is a preferential looking test. First is the Teller Acuity card, which is a high contrast grating of various spatial frequencies, 12 centimeter into 12 centimeter, centered on one half of the card. We start with the largest grating chart and show it 2 to 3 times. We look for the direction in which the child is looking. So the newer charts come with a peephole, and the examiner can look at the baby or the toddler through the peephole. Distance for testing is 38, 55, or 88 centimeter. This test requires a trained personnel. This is a score sheet for Teller Acuity card. Here the details of the child are filled along with the name of the examiner, the testing distance, and the score is in cycles per centimeter of surface. Also, with the charts, we get age normalized graphs for monoocular testing and binocular testing. The vision of the child can be marked on these charts, so we know whether the child lies in the normal for the age or not. This is for binocular vision testing. Next, grating chart is the Leah grating paddle. It is also a preferential looking test, consists of 4 paddles printed on each side, and the grating levels are printed on the handle. They are from 0.25 to 8 cycles per centimeter of surface. Another important test for this age group is Cardiff Acuity cards. They are of vanishing optotypes. Basically, they have a white band with 2 black bands, which are half of the width of the white band on either side. The pictures are either on the top or the bottom of the chart. This is mainly because to detect the movement of the eye in babies with congenital nystagmus. So it is easier to see whether the baby or the toddler is looking on top or below. Age group for examination is 1 to 3 years. These charts can also be used in mentally challenged patients, and there are 3 cards for each acuity level. So this is a type of recognition and resolution acuity. Testing distance that is preferred is 1 meter. We look for immediate eye movements of the child, but older children do tend to point towards the card, like seen in the video. Endpoint is taken as highest acuity level with 2 consecutive correct estimates. Now the calibration for these cards is given in Snellen as well as Logmar equivalent, but we cannot directly compare it to the Snellen chart at 6 meters because this is done at 1 meter, and any uncorrected refractive error will make a difference for checking vision at 6 meter at a Snellen chart eventually. Also, here the child only needs to resolve the target and does not need to identify it. Drawbacks for all these tests: we need a trained personnel, it takes time. Assessment does depend on the motor system. We tend to overestimate vision. Grating acuity cannot be precisely correlated with Snellen acuity. And here the examiner should not know in advance where exactly is the position of the target. A little older children can cooperate with pre-illiterate E-cutout test, isolated hand figure test, pictorial vision charts, HOTV test, broken wheel test. Coming to Lea symbols, this is a very reliable test based on logmar chart. Advantage here is all charts blur out evenly to circles and there is very low chance of guessing. Now the child has to match symbols shown at a distance to a three-dimensional puzzle at near. So children who cannot verbalize or are shy, this test is very useful for them. Next is the K picture card. It comes as a linear crowded book or a single optotype book. This is used at 3 meters, comes with a near chart and a matching card. So in the crowded book, there are a row of 5 boxes to provide consistent crowding. Here we do tend to overestimate the visual acuity because guessing is possible. Next is Allen picture charts or a projected picture chart which is available now. The disadvantage for this is there is no matching card available, so it is difficult to do in shy children, and symbols also do not blur out equally. Broken wheel acuity cards is very sensitive test. Here the wheels of the car are replaced by a Landolt C symbol. Sheridan-Gardner HOTV test is similar to Lea symbols with 4 letters HOTV that are used. Testing distance is 10 feet and a matching card is available. Now these tests are all useful to determine gross visual acuity, but they cannot be compared to any standard chart and they are not usually repeatable. We always have to record the testing distance, the method used, and the name of the examiner. Coming to dynamic retinoscopy, here the target is placed on the examiner's retinoscope. It is helpful in detecting hypoaccommodation in trisomy 21 or in cerebral palsy. Versions can be easily tested in preschool children, but for testing ductions, we need a cooperative child. Doll's head maneuver is also useful by giving short amplitude jerk movements to the neck, making sure that there is no neck abnormality in the child. The second part, by this time, we should have developed the child's confidence. We start with more close examination. We first check the fixation preference. We look for resistance to closure of any of the eye. We look whether the fixation is central, steady, or maintained. Autorefractometer is a big no. Good cycloplegic retinoscopy is a must. Subjective refraction depends on the child's cooperation. Here the motor part of strabismus assessment is completed. Pupillary reactions need to be checked. Corneal diameter can be easily checked by clinic-based digital photograph technique. A photo is taken with a millimeter scale parallel to the limbus, and later we can zoom in on the photograph and get an idea of the corneal diameter. Ptosis with amblyogenic risk has to be detected and treated on time. Tonopen and eye care tonometer are very useful. Perkins is reliable but needs sedation. GA agents usually decrease the IOP, and crying forceful opening will increase the IOP. Direct ophthalmoscope with an interesting target is mostly successful in examining the fundus, and it is very important that all the efforts that the child has put in should be rewarded with a small praise or encouragement at the end of the examination. Thank you.
Thank you, Dr. Tejaswini. A very comprehensive talk. Any questions?
Good morning, sir. I have a question that for children less than 2.5 years, which is the best test for vision testing, which can be used in a private practice? Whatever you have shown as in an institute, where these expensive, they are very expensive, the contrast grading. So I would like to ask Dr. Vayambe sir or Dr. Abhakar Reddy madam, with respect to the chairpersons. Is it okay, sir?
Yeah,
please.
Yes. Less than 2.5. Okay.
The thing is, you can ask them to, if you can see that the patient is trying to make like finger like this.
Okay.
That means vision is good.
Okay.
You cannot ask them to show P because it is difficult. But you can, or you can
Just-
ask them to imitate your actions like this.
Okay.
It gives roughly.
Roughly.
And we are interested whether there is cross difference between the two eyes. We are not here to make out how
The
much is
pinpoint.
vision, 6 to
Yes,
6.
16.
We
Yes.
want to exclude abstract.
Ablabia.
So these can be used.
So the two things important would be, one, you want to know whether it's a bilateral subnormal vision or a unilateral subnormal vision. For bilateral subnormal vision, you'll take history from the mother and you'll see the response of the child to various stimuli of different sizes. So that would give you a relative idea as to the possible visual acuity of the child. A lot of it depends upon the parents noticing how closely they are related, interacting with the child and the routine. But 2.5-year-old child is now fairly active and responsive to various stimuli, so you'll be able to estimate, and the parents will be able to give you a fairly good understanding. Also, you'll get to know why the child has come, so it will give you an idea of what was the primary reason for them at 2.5 years to consult an ophthalmologist. So that is one. And if you're looking at unilateral, just covering one eye, either eye, is a very, very sensitive way to pick up if there is relative visual difference in either eye. It's extremely sensitive. The child becomes unhappy the moment the fixing or eye or the better eye is covered. So that would be a very good screener. And subsequently, of course, for that age, as you said, yes, Cardiff, unfortunately expensive, but is probably the best method to assess for visual acuity at this age of children, and it should be done for binocularly and, of course,
but if we have to publish or write a paper, I need, a private practitioner needs to invest in a Cardiff only, or we can do it.
Unfortunately, I would say that if you are, if you are publishing,
Yes.
then obviously you need to have
Something which is
something
standard.
which is objective, because all these, of course, are fairly reliable from an understanding the possibility or like a screening test, but they do not conform to appropriate. You don't know what is the level of difference. Even it's very difficult to say how much visual acuity difference a child would react abnormally to. So that's the reason why for publications, or if you are doing some kind of research, it would probably not be acceptable.
Okay. Anything else other than Cardiff, which is a little
So
less
Appaswamy, if you contact Appaswamy, they have they can put their pictures on your distance Snellen charts also. And then you can play like a flashcard with the mother, taking pictures and then putting it on an A4 paper. You can tell the mother that train the child to identify these things and then come back the second visit and you can make it like a game.
Yeah, okay.
Yeah, I think the most important aspect is to make it as a play. Child will not understand I'm in the institute or in a private practice or anything. What the child understands is that visit. So I would classify into 3 groups, whatever. Excellent presentation, whether the child is pre-verbal or preschool. These are 2 different categories. And the third and the most important, most of us will get referral is the special children, be it development delay or even autistic children. You can't talk about all this TAC, all that, it's not possible. So institute versus private practice, the space, the money, everything matters. Leah paddles is a very, very good alternative, both from a child's attention point of view and also from publishing point of view. So,
So we have Leah symbols for above 2.5, they
Leah
can match.
paddles,
Okay.
Leah paddles, which can be used in any clinic.
Okay.
In fact, there are comparative studies.
Okay.
We also have published the comparison, but many studies are there which are comparing both the things. So that's what we need to do. And the second tip for the people who see children less, I want to give is just make sure that why the parents have bought. Because in kids at this age group, history, examination and strabismus evaluation and the vision goes hand in hand. It's not a separate compartment. I see optometrists coming from a adult ophthalmology clinic and trying to put one eye, sit properly with the... This is not going to work in a preschool. You need to understand the child psychology. So that's very, very important. And then if they have a squint or anything, don't pass that, probably pass that eye first and then check the other things. And as Rohit said, the central steady maintained fixation gives a lot of information, especially if you want to take a critical decision. These are the things I just added.
Thank you, sir.
Thank you.
Can I add something to that? I was coming to that, the question, but these are some things which I do in my OPD. Just correct me if I am wrong. So these are the Appaswamy has the symbol charts. What I try to do is test binocularly initially. If the child responds, then turn to an uniocular thing. If the child does not respond, then what I do is switch off the light, okay, and try play the mobile from a distance, okay? Because I want to check whether the vision is central, steady or maintained. So if the child is again looking at it, so I have a rough assessment whether the vision is correct or no. And in case that is done, then close one eye, ask the parent to close one eye and test it, as simple as that. Also what I try to do is, in case it's the first visit, I ask the patients to go back to their homes with and show and teach the children the aeroplane, the car, the whatever the symbols are, apple. So these are the common symbols on the chart. Once they do that, I call them back again, okay, for a follow-up visit, and that's when I retest the vision. So it's a, I think, continuous process for me. That's how I take it. Please correct me if I'm wrong.
Excellent, perfect practical points, whatever you said. I would teach what is probably available. You said aeroplane, all that. I would say what is available in your clinic.
On the
Maybe
chart, on the chart.
HOTV or whatever it is available, you can give them a printout, they can read. And don't get really panicked with the child is not, they feel like they have failed the test. Don't make them miserable. So that's very, very important. When they come next time, encourage them. Sometimes for each letter, we have to respond. It's a time taking, in strabismus or whatever clinic, pediatric clinic, the most time taken thing is this one.
Yeah.
Visual acuity estimation. Most important.
And first time may not be the best time to put them to any major tests. So you in fact have to discuss that for the first time with the parents, that we are purposely not subjecting the child, say, to dilatation or things like that, because the first experience in the clinic, they used to white coat doctors being pediatricians who keep poking them with all kinds of needles. So the moment they see you in a white coat, and especially now with a mask, they're rather daunted by the appearance. So they are very scared. So first couple of visits, definitely the first one should not be an uncomfortable visit for the child. He should be happy. He should feel that, yeah, this was a nice place to visit and I don't mind coming back again. And again, for dilatation, I advise the parents that you do the unpleasant job at home. Even if it's a drop dilatation, I would ask them that to do it at home. They associate the unpleasant task with you and not with me, so that when you come, you are dilated and I don't need to put you through an unpleasant, in a crowded OPD, an uncomfortable activity. So absolutely right. You need to, and every patient you need to see, how the child is responding, and even when you're taking history with the child in the parent's lap, you keep one eye on the child and see how he's behaving, and you can ask the parents to, cover either eye quietly. And these are ways, as you said, it's just a time-taking process, and you need to repeat continuously.
I completely understand the pediatrician point of view because my wife is a pediatrician.
We all are scared of wives here, so you can't tell that to the child.
I think we should move on to the next talk. Can I invite Dr. Rakesh Prabhu? Is he here? Siddharth, would you like to discuss?
Siddharth, you could make the few key points you want to make. We'll take a little
Key points on
discussion.
prescribing glasses in children.
You just have to make sure that you're either you invite all of us to attend that talk, or
Give us the key
give
points
us
here.
the key points from. You can come to the mic, and without a presentation, I'm sure you'll be able to tell us a lot about those key points.
Can I quickly add one thing? There is this
Dr.
peak acuity test which is being done for home testing in adults. I'm not sure whether we can do it for pediatric patients, but maybe that would be a good option. The peak, the ones with the lines.
It's good for school-going children, not for preschool and toddlers, what we are talking about right now.
Okay.